talk about neurological disorders. Let's go through this. We have, when we're observing someone with neurological disorders, we want to talk about history, mentation, right? We want to talk about, we want to monitor their systems, the muscles, coordination, movements, right? Reflexes. What are some reflexes that we want to make sure if they have or don't have? Deep tendon. Gag. Yep. And if it was like a baby, when we get there, what would we see? Babinski. One of them, sure. How about sensory systems? What are we looking for? Touch. Temperature. Those dermatones things, right? Neurocheck. How are we figuring the neurocheck? What are we looking at? Pupils. Client's response. Are they alert oriented? That kind of thing, right? Okay. Here's the neurocheck. We're looking at the level of consciousness. We're looking at the pupils, the motor strength, the reflexes, right? The Glasgow Coma scale. What does that tell us? Mm-hmm. Yeah. Cool. All right. So how do we diagnose problems? What's a CT scan do? Brain. Okay, so it's like it's a computed tomography. So it takes pictures, X-rays of the whole body, tells them what they see, the veins, the everything that they need to know, right? And do they use dye? They can. So what do we need to do before we allergies? Yep. And get what? Consent. Get consent. Okay. How about the cerebral angiogram? Same consent. Clear liquids before, void before procedure. Okay. How about MRI? Anything special there? No metal. Yep. Consent. Yep. Body piercings. Okay, let's talk about increased intracranial pressure. What are we looking at with increased intracranial pressure? Level of consciousness, right? We're looking at the CNS. Usually what happens? Why do they have increased intracranial pressure? A trauma, injury, a stroke, yep. A tumor, a bleeding, so that's kind of trauma. It could be fluid, hydrocephaly. Infection. Could be infection, meningitis. We're going to see that next. Okay, so what are some manifestations? What are we going to see? Headache. Lethargy. Confusions. The pupils. Hypertension, yes. Mm-hmm. The Cushing's triad. We can also have the Brudzinski sign. What's that again? Yes. So intracranial pressure, right? They could have that if they had the meningitis. But since we're on the topic, how about meningitis? What do? A lumbar puncture. Yeah. How do we know they have it? What would we see? Cloudiness. Yep. Stiff neck. Mm-hmm. Headache. Right. It can cause seizures. Sensitivity to light. Okay. So early meningitis may be similar to the flu. So we have to check all these things. What are some nursing interventions?
Keep the head of the bed.
Mm-hmm. Dim lights. No stimulation. Don't cluster activities. Yes. And definitely check for that Brudzinski sign, right? Which has to do with the legs and the moving the legs and the neck, right? No, hips and knees. Sorry, hips and knees.
There's another one. There's
Koenig's and the Brudzinski. Yeah. Okay. How about if the person has hyperthermia? What are we seeing in manifestations? What do we see? High temperature, right? Yes. So what are we gonna do? Nursing intervention. We're monitoring the vital signs, cooling them down, hydrating, looking at skin changes, looking at level of consciousness, right? Because if their temp is too high, they start breaking down proteins, and then we have problems, right? Okay. What if it was hyperthermia? Hypothermia. Warming blankets. Yeah. When do we have a possibility of that, other than if we're out in the cold? What's a time after surgery? Yeah. So we want to make, because we know that everything is depressed.
You see it after cardiac arrest as well.
Oh, the clamming, because they have the clammy, cool. Yeah, you might, but it wouldn't be as bad as hypothermia that I know of. But it's more like because of the CNS has been depressed now, it can't kick back up to reheat the body, to tell the body to reheat. Okay, let's talk about seizures. Okay, so classifications. What are the different classifications? Tonic-clonic. So generalized, absent, and partial. Right. So those are the three main ones. Yes, status epilepticus means what?
It's a prolonged seizure.
Of up to how much would it tell us? 30 minutes, right? But it doesn't necessarily have to be 30 long minutes, but it could be very short intervals in between. It's not enough for you to really catch your breath. And so that could be a problem there too. So how do we deal with it? What is it? Medication. Sure. What once you see it, what do you do during the seizure? Lie them on the side. What else? Nothing in the mouth. Yes. Okay. And give them dignity. What else? We also want to know how long. So we're monitoring how long. We also want to know where, like what parts of the body was affected, right? Not the quality, the characteristic. Okay. What does it matter about the length of time? Why are we worried about that? Who are we worried about it for? Yeah, because it's exactly the oxygen levels. While you're seizing, you're not breathing. So we want to know how long they've not been breathing for. So do we worry if the person is a known person with a seizure?
Yes.
When do we worry?
When what do you mean?
So usually when they have a seizure and we know they have a seizure, and we know they just, like, what do we do? Like, are we worried? We're not worried in the sense that we know they have seizures, right? So we know we need to get their labs, and they're probably low threshold on something, right? So that's not necessarily a worry. We worry mostly when the length of time extends what they're used to, right? So that worries us. Or if it's a brand new seizure, we don't know why it's happening, right? Febrile seizures are another one that reasons behind seizures. Let's see what else. Length, size, aura is something else we haven't mentioned, right? What does aura mean? What's going to happen before? Yeah, before the seizure. Okay, and it could be smell, it could be a feeling, it could be different things, right? Let's see. Okay, let's talk about some of those medications. Name some. Keppra. Okay. Yes. Dilantin. Gabapentin. Phenytoin. Yes. Phenobarbital. Depakote. Yes. And which ones are we? Most of them we have to what? What do we have to do if we know they're on those meds? Draw levels and make sure. Look at the therapeutic levels. Let's see what else. You can. Do I have it here? Do I have benzos here? I don't have benzos here, but you can. What else? We're monitoring the oxygen. So oxygen at the head of the bed elevated, right? Diazepam, we can use that. Okay. So, and we just talked about the epilepticus. What else can we talk about? No more. Okay. Let's talk about a CVA. What's happening here? Yep. So, blood clot in the brain somewhere. What's the risk factors? Hypertension. Obesity. Smoking. I wouldn't say older age. That's not part of that. But say diabetes. Yes. Aneurysms. What else we have? Cerebral hemorrhage. Say it again. Birth control. Yes, that's a good one. Okay, so now we have it. What do we do? What do we see? The person had it. How do we recognize it? Facial drooping. Can't smile. Hemiparesis, right? Right side, left side, brain opposites from the body. Say it again.
They can't talk.
Yeah. Slurred speech. What else? We have the hemiplegia. We have the aphasia, right? So we mentioned the right and the left hemisphere. So the right side affects which parts? Sensory, visual. Left side affects the speech and language. Okay. All right. So what do we do? That is a fact, right? We want to assess them. We want to make sure like we know what is their deficiencies, right? Because that's what we're going to cater to. We want to ask about their psyche, like how this is affecting their life. Now they lost a whole left side, right? We also want to, how do we care for them? Okay, they don't have the left side. They can't see on that side. They don't think even it exists. So we tell them scan the room. We have to approach them at the side. That is good, right? Certain things like that. How about the aphasia part? Well, how do we communicate with them? Right? Yeah. We could show pictures. Yes. Right? Do we speak louder? No. But allow them to what? See your mouth. Yes. Yes. Clearly and slowly. Okay.
What if you have a mask mandate inside the room?
Then you use writing or pictures. It's always a way out. Okay. Spinal cord injury. Okay. What's the cause? What can happen? Trauma. Infection. What else? Tumors. Mechanical.
That's what happened.
Yeah. So, level of injury. What are the 3 different levels?
Thoracic, cervical, lumbar.
Lumbar. Which one's worse? Cervical. So it's 1 to 3. If it hits below, you get what? Quadra or respiratory issues. So 3, I think 2, you're dead. Honestly, 3 and 4, I feel like that's when you get quadra, and then lower than that is para. Okay. So what else? Paralysis of all 4 quadrants. So that's the cervical, entire lumbar. So lumbar, if it's lumbar, where is usually the pain or problem? Lower legs. Yes. Let's see anything else. How do we help these people move? What's the important thing about movement? What's that? Log rolling. Yeah. So we don't want to bend them forward, especially if we don't know what the injury is, because inflammation will happen naturally and enzymes get secreted and it becomes a problem. Okay. What's other things that we're worried about when there's a spinal injury? Breathing, we mentioned. Okay. Yes. What's that?
Like a crumb on the bed can make you like anxious or something.
They have a full bladder.
Yes. Yes. So monitor for autonomic hyperreflexia or dysreflexia. Yep. So we definitely want to maintain their respirations. We want to check their blood pressure. How about bladder and bowel? Right? Depending on where, they might not have use of it. Right? How about sexuality?
Oh, you don't teach about that.
Yeah. Spasms, pains, right? Maybe they don't have any pain, but we still have. I had a patient once who he was paralyzed from the neck down, and so I had to catheterize him. Yet he would have an erection. And it was a problem for many of the nurses because they thought he could control it and he's doing it on purpose, but he wasn't. It was just a reflex of the body, right? But yeah, so you definitely have to consider the bowel, the bladder, the sexuality, all of that. Okay, moving on. Parkinson's disease. Tell me about Parkinson. We're going through quickly. So do we know the cause? Not really, right? So it has to do with dopamine in the brain, how, the chemistry part, that's nice to know things where the receptor doesn't receive, it doesn't let go, and it doesn't use up. Anyway, how does it manifest? Shuffling gait. Ataxia, rigidity. What's this? Tremors. Pill rolling. Yes. Drooling. Constipation, depression. Speech. Yeah. How about this? Flat affect. Yes. Yes. So they have different stages, right? So it could start with a shuffling gait and it progresses to difficulty of the ambulation, to weakness, to disability, right? So the main thing is a lot of times they need mobility. They need like that momentum. So that's how you want to help them. What are some drugs to medication to give? Levodopa, carbidopa, yeah. Cogentin. Okay, let's see. So, and the idea is those are the only drugs that cross the blood-brain barrier. One of the very few, we should say, right? They work that well. Nursing interventions. What do we do to help them? Nursing intervention. We already mentioned like kind of helping them with the movement because they're stiff and hard to move. What else do we do? Skincare, right? Encourage self-care. Don't do everything for them, right? Because you don't want them to lose their independence. Educate about food and diet. Since they get constipated, they want to have fiber in their meals, right? Since it's hard for them to walk, you want to make sure it's lighted so that they can see where they're going, right? And they might need to use a rocking chair in order to help them get up because they can't get up on their own. All right. So other nervous system diseases, I put them all together because most of these are what? There's a problem with what? Yes, this was the whole thing. Muscles. There's a problem with muscles. Guillain-Barré, what's the problem with the muscles? Well, first of all, how do we know it from something else? Like, how does it start? That's the question. How does it start? A person who had this usually what?
I feel like that's like a facial one, but I could be wrong.
No, they usually had some kind of respiratory disease before, and then it progressively gets this way. How does it progress? From the bottom up, right? Like most of these, right? Let's see. So they start losing the functionality of their legs, then their bowels, bladder, and then eventually it gets to the lungs, and then they lose that ability as well. Do they get better?
Yes.
Yes, they do. How long does it take usually? A long time, like 2 years. A long time, right? So so since we know those kind of things, like what are we worried about? Breathing, yes, breathing, right? Movement, they can't move anymore. What else? Let's see. Yeah, that's about that. How about multiple sclerosis? Oh, and emotional too. Emotional, because emotionally they are altogether there. It's just their body is giving up on them, right? Same thing with multiple sclerosis and myasthenia gravis. Okay, so tell me about multiple sclerosis.
Unknown causes.
Yep.
It can be like it's like an autoimmune.
Yes, autoimmune, definitely.
So there'll be remission and exacerbations.
Yeah. So the sheath, myelin sheath, there's a destruction there, and the myelin sheath are the little thing, the coating around each cell that causes the cell action or signal to go faster until it gets to where it's going. But since it's being destroyed, it slows down and goes away, right? Kind of like Alzheimer's, but different. Okay, so what are we going to see? Weakness, yes.
You could see like bowel and bladder.
Bowel and bladder, yep. Blurred vision, tremors, nystagmus, dysphagia. Let's see. They sometimes have decreased feelings of pain or sensations. What would we do for them as nurses? What are some of our interventions?
MS.
Yep, for MS. Safety, yes. Help them to conserve their energy since they get weak, right? Urinary infections or bladder issues, right? Anything, skin integrity, right? What else?
ADL.
Yes, help them with ADLs, exactly. Assist with daily living, regular exercise, right? Okay, myasthenia gravis. What's the problem there?
Paralysis.
It's a neuromuscular disease, and it's not all paralysis. It's more like this overly exaggerated fatigue of the muscles, right? So it's not really quite paralyzed, okay? So it's a abnormal fatigue of voluntary muscles, a defect in the transmission of nerve impulses, okay? It's caused by acetylcholine. Let's see. So what do we see? Weakness, yes, activity intolerance. And a lot of times it gets triggered. It comes and it goes. MS has exacerbations, but it can go back, but not, it's kind of like, what's another disease that has exacerbations but doesn't go back? COPD. So MS is kind of like COPD. Once it gets to a certain extent, like the improvement is very minimal. So you don't want it to keep progressing, even though naturally that's what it does. It progresses, right? So anything like stress, disease, whatever, you want to kind of minimize it. Same thing, but different from myasthenia gravis, they get exacerbations, but similar with COPD is multiple sclerosis, asthma is myasthenia gravis. They can go back to their original selves again, and like nothing happened. Okay. But they get exacerbations as well because of a sickness, because of too much exercise, because of too much stress. Okay. They also will have difficulty breathing. They will have, let's see, what else? Weakness, hoarseness. What's ptosis? The drooping eye, right? Speaking of ptosis, what's another disease that has a drooping eye? That kind of looks like a stroke. Bell's palsy, yeah. Okay, so what are we going to do for myasthenia gravis people? How are we going to help them? To preserve strength. What's a Tesla test? So that's in those patients, right? We find out if the acetylcholine, it has that in it. So if we give that to them and they feel better, we know they have myasthenia gravis. Right? If we give it to them and they had myasthenia gravis, but it gets worse, that means they had a crisis. They had taken too much, right? So that's something to remember. Okay. Let's see. Myasthenia gravis differentiation. Okay. Positive for the injection of the edrophonium is administered to the gland. Okay. So that's that. Okay. Let's look at trigeminal neuralgia. What's that one? What's another word for the trigeminal nerve? Cranial nerve 5. So you got to remember your cranial nerves and what they do. Okay. How many do you have again? 12. Right. I haven't added it here, but I'll add it. I feel like it was more like anatomy based stuff, so I didn't add it, but I can add it if you need me to. But definitely remember, because that helps when you know what nerve they're talking about. So we have sensory disorder of the trigeminal nerve, cranial nerve 5, result in severe recurrent sharp facial pain, right? So this is when, like, how do you identify? How does a person, like, what are their complaints? How do they know that they have it? The pain, where's the pain? In the face. So usually it's like when they're washing their face, brushing their teeth, because it's a nerve that's near the teeth that's in the wrong place, and in order to resolve it, they're gonna have to do a surgery and replace it, put it someplace else. So symptoms include cold, washing the face is stimulated to have the symptoms. When they use cold water, when they're washing their face, when they're chewing, or fluid or food is extreme temperatures. So that's what triggers it. What are some interventions? Since we know the triggers, then we can tell them to avoid the triggers, right? Avoid cold food, avoid hot food, instruct the client to chew food on unaffected side. I had a coworker who had it, and she said it would start with like this numbing pain, and then it will get worse and worse and worse. And if she caught it in time, she takes the medicine, pain medicine, it might help it. But if it's too late, she's just excruciating pain. Okay, then the next one is Bell's palsy, facial paralysis. So this one is caused by cranial nerve number 7. Yep, cranial nerve number 7. Usually it comes from an infection, a hemorrhage, or meningitis, or a tumor. So it's paralysis of what? Which, like the whole face? One side. Yeah, one side. Paralysis of one side of the face. Does it go away? Yes. So recovery usually occurs within a few weeks without residual effects. So how would we be able to tell? What's the test that we ask them to do? It's not really a test. Like, how do we find out? The smile. Yeah. Can you smile? Can you frown? Can you close your eyes? Right? Or puff up the cheeks. Let's see. Sometimes they have lost taste too, loss of taste. So our interventions encourage facial exercise and protect the eyes from being dry. What's another disease we talked about that we had to protect the eye again? Starts with a G. Graves disease. Yeah. So remember, that's what I usually say, like whenever something comes to mind, you're like, there's something like that. Is there something like that? And then you kind of cluster. Okay, oh, we did that in 30 minutes. I'm learning not to put too much down. But that also means that you have to go do more research. But I'm trying to put like the essential stuff on there. Let's see, what's our next one? I went over this to see. Muscles, here we go.